Hello everybody. In this video, we'll learn about anterior chamber examination. There are two things that you will learn and you have to comment in anterior chamber. One is the depth and second one is contents. Okay. So the depth of the anterior chamber is the cornea is usually around 2.8 to 3.5 millimeter in the center. Now, how do you check the anterior chamber depth? So if you throw light from the temporal aspect, the light passes across the anterior chamber and illuminates the opposite limbus. So you will see light on the opposite limbus. So, so we'll see what happens if I throw light on the temporal limbus. The light you will pass on the before, and you will see the nasal limbus getting illuminated. Okay. So if the antechamber is shallow or deep, then you will see differently. Okay. If your antechamber is shallow, please have a look at here. So if the antechamber is shallow, light will not pass across the antechamber and it will not illuminate the opposite limbus. So you see a dark area in the nasal half of the antechamber. So this is called as eclipse sign. Okay. So we'll see what happens in this patient. If I throw light on the nasal, on the left eye, if I throw light on the nasal temporal side, so the nasal half of the antechamber is not well illuminated. This is called as eclipse sign because the antechamber is shallow here. But we'll see what happens if in this, in the right eye, you see that if I throw light from the temporal limb. So if I throw light on the temporal side, the nasal nimbus is markedly illuminated. Okay. So this is a deep anterior chamber, whereas here it was a shallow anterior chamber. So in shallow anterior chamber, light will not pass across the anterior chamber and not illuminate the opposite limbus, and where you see as eclipse sign. Okay, so when eclipse sign is present, the impression is it is a shallow anterior chamber. Let's see the causes for anterior chamber, deep anterior chamber or shallow anterior chamber. Deep anterior chamber, what are the causes? It could be myopia, where the eyeball length is only increased. Axial myopia, where the antechamber will be deep. If the lens is absent, okay, aphakia, then the iris will move backwards and the antechamber is deep. If there's a posterior dislocation of lens is moved backwards, then also you see the anterior chamber deep. If lens is in its position, but if the cornea is protruding forwards, like in keratoconus, keratoglobus, or ophthalmos, then also you see deep anterior chamber. Shallow anterior chamber is seen in case of hypermetropia, where the axial length of the eyeball is small, short, and you see the whole axial length is small, so even the anterior chamber depth is small. In anterior subluxation of the lens has moved forwards, so it will cause a shallow anterior chamber, or phacomorphic glaucoma, where the lens is swollen. Then also you see that it is pushing on the lens, on the iris, and causing the anterior chamber to be shallow. Where you see irregular anterior chamber, you see it in adherent glaucoma, where the iris is adherent. You see here the iris is adherent to the cornea, and in that area the anterior chamber will be shallow and the remaining area it can be deep. And or in case of anterior subluxation of lens is subluxated forward, that part of the anterior chamber will be shallow and the remaining part will be deep. Or iris Bombay formation, where the peripheral iris is protruding forwards. You see the central anterior chamber is deep, whereas the peripheral anterior chamber is shallow. So there also you can have irregular anterior chamber. Next thing we'll comment about is the content. So on torchlight, please remember you cannot comment about contents unless it's a very gross abnormality that you see. So flare and cells are only seen on slit lamp. Flare is nothing but the proteins which are present. Normally, antechamber is optically clear. You will not see anything. Okay, but if you see, if there are proteins in the aqueous, you will see them as a haze. Okay, so it is seen as a haze in the antechamber on slit lamp examination, and this we call it as flare, which can be graded. That we learn in a different video. And cells, you can also see cells. You can see cells distributed in the aqueous, and you will grade them according to the number of cells in each in 1 by 3 millimeter slit. Okay, so this is only seen on slit lamp. It cannot be seen on torchlight. But on torchlight, can you see anything else? If there is presence of blood, which is called as hypema, you can see blood in the anterior chamber. If there is presence of pus, like we call it as hypopion, you can see pus in the anterior chamber. Sometimes lenticular matter, like in phacolytic glaucoma, you can see lenticular matter in the anterior chamber. You see here there is lens cortical matter present in the anterior chamber. This is called as pseudo hypopion. Not it is not a true hypopion. It is not pus, but it is a pseudo hypopion. We can also see sometimes cells like lymphoma cells, which are masquerading as hypopion. So, this is a case of lymphoma where the patient presents with blood tinged hypopion, which actually drastically disappears once you treat the lymphoma with systemic chemotherapy, right? So, in summary, you will comment about the torchlight on torchlight examination, comment on the depth, whether it's normal, shallow, or deep. Okay, if it's normal, just say it is normal. If it is don't comment that eclipse sign absent. Okay, if you see eclipse sign, then you say I see shallow because I see an eclipse sign. Do not comment about cells or flare on torchlight examination, and only if you see hypopion or hyphema, you will comment on the contents. Okay. Uh, Most of the students are of the habit of saying normal depth and no eclipse sign, no hypopion, no hyphema. So you don't have to talk about negative history, I mean examination. So if whatever you see, you comment, but don't comment about things that you're not seeing. Okay. Thank you very much.